Hey everybody, this is Kevin Bassett at TheDietWars.com, and you may have heard when looking around on social media and even on some health websites that lower LDL cholesterol or lower total cholesterol is associated with a higher risk of death. So you want higher cholesterol, higher LDL cholesterol to have a lower risk of death, because if you have it too low, you're going to have a higher risk of death. Make sure not to get your cholesterol levels too low. That's dangerous. This claim is made based off of a really large literature, more than 50 years old, of observational studies where they look at what is your cholesterol level or your LDL cholesterol level, and how often are you going to die, or what is your frequency of death, your risk of death in, say, 5 or 10 years of follow-up. So they take all the people that, say, have a 70 milligram per deciliter LDL cholesterol level, all the people with 80, all the people with 90, all the people with 100, and say which proportion of each group dies. And what they found in these studies is that the people with lower LDL cholesterol, like 70, 80, 60, have a higher risk of dying whenever you follow up on them. You follow up on them, you find more of them are dead. And this is referred to as the cholesterol paradox. Dozens and dozens of papers have been published on this showing this in many, many different populations all around the world. It's a well-established phenomenon. It shows that if you have a really low level of LDL cholesterol, you have a much higher risk of death. Okay, so then therefore some people conclude from this that you should therefore try to have a higher LDL cholesterol and a higher total cholesterol that's more healthy, because it's going to reduce your chance of dying. This conclusion actually, though, is not based in the evidence. This is only one subsection of studies, and it is a very important subsection of studies because it helps us to understand the relationship between LDL cholesterol and death. And it needs to be done. These studies need to be done in order to confirm that LDL cholesterol levels are reducing them is a good thing. But it would be a misinterpretation to suggest that these studies indicate that you should maintain higher LDL cholesterols in order to avoid death. This isn't supported by the evidence. And in this video, I'm going to explain why that's the case. So here is this paper. It's called, and again, this is just like 50, 100 different papers, a million different papers that are showing the same thing. It's called Association Between Low Density Lipoprotein and All-Cause and Cause-Specific Mortality in Denmark, a prospective cohort study. Okay, and as we can see, when we look at the first figure, the more your LDL cholesterol, the greater your risk of all-cause mortality, death from any cause. Okay, death from any cause. The higher your LDL cholesterol, the higher the risk if it's really high, but if you get to a certain point, about 140, you have the lowest risk of death from any cause. And then when you get really low, you have much higher risk. In fact, the low people who have really, really low have a higher risk of death than the people who have really, really high. Okay? So again, this demonstrates this so-called cholesterol paradox, and it's an important thing to remember and to think about. But we need to place this in the right context. So let's look at the way that the study authors, tried to explain this. It says possible explanations for our findings. The association between low levels of LDL-C and an increased risk of all-cause mortality could be explained by reverse causation. Debilitation and illness have been hypothesized to cause a decrease in levels of cholesterol. And I'm going to interrupt right there before I continue reading to explain what they mean by this. So, if you have a debilitation or an illness, it can cause your low LDL cholesterol, and then it can cause death. But the thing that's causing death is not the low LDL cholesterol, it is the illness. The illness is causing both the low cholesterol and the increased risk of death. It's not that the low levels of LDL cholesterol are causing the death. Each are being caused by something else independently. And again, LDL cholesterol is itself not leading to the greater risk of death. So if you increase it, let's say you have this kind of illness and then you increase your LDL cholesterol, you're not going to decrease your risk of death whatsoever. It's not going to help you at all because the LDL cholesterol isn't causing the death. It's something else causing the death, and the low LDL cholesterol is coming along for the ride as a marker of that thing. Okay, so we're going to continue reading. It says, and in this study, comorbidities were more frequent in individuals with the lowest LDL-C. Also consistent with the theory that low levels of LDL-C are an indirect marker of severe disease, the association between low levels of LDL-C and the risk of all-cause mortality was strongest in the age and sex-adjusted model, but substantially reduced when adjusting for baseline comorbidities. That is to say, if you adjust for disease, you see a much reduced association between low cholesterol and mortality, suggesting that much of that association is due to these diseases, but not all of it. So look, it says an association remained after this adjustment, however, and after excluding individuals with less than 5 years of follow-up and known cardiovascular disease, cancer, and chronic obstructive pulmonary disease at baseline. So this association remained no matter what. They can't get rid of it by just getting rid of all the people who have diseases. It's not important to read the rest because it's going to say what I'm about to say already. They adjusted for cardiovascular disease, cancer, and chronic obstructive pulmonary disease, but the key word here is known. It's known, right? There are other people with diseases that are not known that are going to cause low cholesterol levels and that are therefore going to drive some of that remaining association with death. And that's my interpretation of this literature. Now, we need to understand why that's the case. Why is it the case that low LDL cholesterol is caused by these diseases? And how does low LDL cholesterol get caused? Like, how do these diseases cause low LDL cholesterol? Because once we understand that, we can get a clearer, plausible understanding for how we explain this literature. Okay? So we're going to start with this paper. It was published last year. It's called Malnutrition Affects Cholesterol Paradox in Coronary Artery Disease, a 40,000, essentially, person Chinese cohort study, or in this case, 41,229 Chinese cohort study. Essentially what they did is they adjusted for nutritional status, and they write, after adjustment for nutritional status, the risk of all-cause mortality in patients with low LDL-C levels decreased. So in fact, it went from high risk of death from low LDL-C to low risk of death from low LDL-C once you adjust for nutritional status. That's interesting. In the final multivariate Cox model, a low LDL-C level was related to better prognosis, about 10% better. The conclusion is this study demonstrated that the cholesterol paradox existed in coronary artery disease patients but disappeared after accounting for the effects of malnutrition. That's interesting. Before we continue and explain this in greater detail, I want to also mention a similar study showing a similar result called Association of Resting Heart Rate and its change with incident cardiovascular events in middle-aged and older Chinese. And this is a similar sort of association, paradoxical association. So we know that having a low baseline heart rate is associated with better outcomes. Because people are in really good shape, they have good cardiorespiratory fitness, they have a lower heart rate. So me at night, I have a heart rate as low as like almost as low as 40. During the day, I have a heart rate in my 50s. So I'm like right at the bottom of this figure. But interestingly, in this population, in other populations, it's different. In other populations, they show that the higher your heart rate, you actually have a higher cause of death, and they don't tend to show at the lower end a lower cause of death. Sorry, a higher cause of death at the lower end. But this is one study where I found that, and there's several studies that show this. So it depends on the population you're talking about, probably because of differences in BMI. It's not important. but I want to talk about this figure in particular. So even though athletes tend to be like down here at the very bottom, right? And they tend to live longer. The people with the lowest baseline heart rates had the highest risk of death. Well, why? It's probably the same thing, man. So it's probably malnutrition issue. But why would malnutrition cause a lower heart rate? Let's dive into it now. So here is a paper from 1974, in fact, called The Effect of Body Weight Changes on Plasma Lipids in Patients with Primary Hyperlipoproteinemia. It's by Litsch, Bolzano, Erbst, Saylor, Sandhofer, and Braunsteiner from the University of Innsbruck in Austria. Okay, so what they found when they took people who had genetically high levels of cholesterol, and they severely restricted them calories. In fact, they did total starvation. What they found is, of course, they found a reduction in their body weight, and they did this, I think, for a couple weeks. They found a reduction in body weight. They also found on almost all the patients, no matter what the genetic problem was, they found a drastic reduction in cholesterol, blood cholesterol, from short-term starvation. Now things are starting to come together a little bit. Think back to what we just saw. People with cancer, people with chronic obstructive pulmonary disease, people with cardiovascular disease, people with severe diseases often start wasting away. In fact, we know that about cancer especially. It's called cancer cachexia. So people with cancer cachexia start losing weight. They drop weight. They're in a state of calorie restriction. Okay? So anybody in a state of calorie restriction can start to get lower cholesterol levels. Okay? And generally, the people in severe states of calorie restriction are people who are sick. Now, in this study, they said they ruled out people with known cardiovascular disease, known cancer, known chronic obstructive pulmonary disease, but what about any disease that causes a weight loss? Any disease that causes a weight loss. If it's not detected, you can't exclude those people from the analysis. Okay? That's a big reason why I think that this study is showing what it is. It's because there's people who are sick who are not being excluded from the analysis. Now let's look at this other study. So this just shows the same thing, but this shows in long-term calorie restriction, it shows the same thing. Long-term calorie restriction is highly effective in reducing the risk for atherosclerosis in humans. And what it just shows is that serum cholesterol, low-density lipoprotein cholesterol, LDL-C, is lower in people who have calorie restriction. And we can see that here. LDL-C compared to controls, it's about 50% lower. 50% lower LDL-C and about 25% lower or 30% lower total cholesterol. So when you severely calorie restrict, experimentally, you get lower cholesterol levels. Now this suggests that the reason that many of these people who are having a higher risk of mortality are sick people who are in the state of calorie restriction. Okay? All right. Here is another paper, and I'm actually not drawing from it what the original authors had intended. I'm just going to demonstrate a basic concept of mammalian biology. It's called Calorie Restriction and the Aging Process, a Critique. It's by Sohal and Forster in the Free Radical Biology and Medicine Journal, 2014. And here we can see the first figure, something very interesting. If you feed animals ad libitum, they get to eat as much as they want, and you watch their body weight over the course of their lives in terms of months. You can see here at the top bar on this figure, if you're listening, it's just basically a hill. It's like a hill that you're looking at. So it starts at a low body weight naturally whenever you're only a couple months old. And then you progressively increase in body weight when you're fed ad libitum. You reach a zenith at around, 15 to 17 months. Mouse middle age. And then you start to decline. Your body weight starts to decline. So between 15 and 25 months, the body weight declined, total body weight declined 20%. Right? There's a progressive loss in body weight with age. And this happens in old people. So when old people age, and as we age, we'll get what's called, we'll become more frail. We'll start to lose our appetites, probably because we have illnesses or subclinical illnesses or subclinical health conditions. We lose appetite, we lose our vigor, so to speak, and we progressively start to lose weight in old age, which is why many old people become frail. They don't have enough muscle mass. They lose a lot of muscle mass. And they get what's called sarcopenia, which is actually a critically low amount of muscle mass and causing a lack of physical function or an inability to function physically because you just don't have enough muscle mass. And this happens because of this process, in part because of this process, most of it because of this process, a lack of activity, being able to move as much to maintain the muscle, and then also just a lack of calories. And so you lose the muscle and you're not able to maintain the activity to maintain it because you're losing body weight. And experiment after experiment in mice-fed ad libitum diets shows the same thing. So no matter what mouse strain we're talking about, we show a peak, around 10 or 15 months, and then a progressive decline in body weight. Okay? And here you can see this C57 Black 6 panel. You can see an increase right near the end. That's just because some of those mice are dying. Well, okay, that's actually perfect. So the reason, this is actually perfectly illustrates the point. The reason there's an increase in the Black 6 at the end of this figure, there's an increase in the body weight, is because the sick mice that had the lowest body weight, the least healthy mice, they had died. And only the other ones remained, and so you have this jump in body weight, it looks like. They suddenly ate a bunch of food. No, this isn't a jump in body weight because they ate a bunch of food. That's because the heaviest mice are still around, because the heaviest mice are the healthiest. That's what that's showing. And this, you can also see this in this F344 rat figure. So this is both mice and rats. They show the same exact biology in this respect. And humans do too. Actually, as far as I know, all mammalian species show this effect. This increase of body weight to middle age, then there was progressive reduction in body weight in a U-shaped form. What does that mean? Well, it means it's really poor health that's driving that. It's the aging process and poor health, and the animals or humans that are not losing their weight and they're older are the ones living longer, and the ones that are losing their weight are the ones dying, not because of the body weight loss necessarily, but because of the illness that's underlying the body weight loss. Okay? And that illness that's underlying body weight loss is, guess what? Not just going to cause body weight loss, it's going to cause lower cholesterol. So the people with the lowest cholesterol have the most body weight loss, have the most loss of mass, and are deep in this process of mass loss and body weight loss. They're the most ill. And these most ill people are going to be the ones with the lowest cholesterol levels. And it doesn't matter if you can detect it as you have a cancer diagnosis or a cardiovascular disease diagnosis or a chronic obstructive pulmonary disease diagnosis. That doesn't matter. What matters is that you're sick. Whether or not you have these formal diagnoses, you have something, or you're just not in good health and you're losing weight and your cholesterol is going down. You're not doing well. What's killing you is the illness, not the cholesterol. Right? The cholesterol is just coming along for the ride. Right? So it's reverse causation is the basic point that I'm trying to make here. Let's look at this. Let's explain and fully pull this out. So the first thing you should know, and I'll just go over this very briefly because this isn't at the heart of everything. The next paper is. But I'll go over this very briefly. The more you reduce your LDL cholesterol through drugs, or through genes that cause you to have low LDL cholesterol over the course of your entire life, the more you do that, the more your reduction in cardiovascular disease risk and heart disease risk. And you can see that very closely here. Sorry, very clearly here. The more the reduction in this figure, the more reduction in cardiovascular disease. And by the way, this paper is called Low Density Lipoproteins Cause Atherosclerotic, and I always struggle with that, atherosclerotic. You can say it slowly, but saying it fast is hard. Atherosclerotic cardiovascular disease, evidence from genetic, epidemiologic, and clinical studies, a consensus statement from the European Atherosclerosis Society consensus panel. And it's a famous paper, it has like thousands of citations. Doesn't mean it's great. It could be a bad paper, but it is a good paper. It just so happens to be a good paper as well. And this shows that if you have these variants that lower your LDL cholesterol over the course of your entire life, you have a reduction in your risk, and it doesn't matter which variant it is. Most variants do this. Most variants related to the mechanism of action of many drugs that we commonly know to lower cholesterol. So, for example, statins work through HMG-CR2. They inhibit HMG-CR2. If you have variants that reduce the activity of HMG-CR2, it's an enzyme, then you have lower risk of coronary heart disease, Same thing with NPC1L1, lower activity of that enzyme, a lower risk of heart disease. Same thing with PCSK9 and ABCG5, G8, which is what these different drugs work on through multiple different mechanisms. If you have low LDL cholesterol, you have low coronary heart disease. And if you have low LDL cholesterol, you have a greater percentage change reduction in atheroma. If you have a low LDL cholesterol, you have a lower risk of heart disease events. So these two figures show that. Cool. But here's the zinger. Here's the banger. Here's the one that slaps the hardest. It's called association between baseline LDL-C level and total cardiovascular mortality after LDL-C lowering, a systematic review and meta-analysis that it includes 136,000 patients, 34 clinical trials. Actually, it's not 136,000 patients, it's 269,000 patients, because 136,000 patients receiving more intensive and 133,000 patients receiving less intensive LDL lowering. And this is the different trials comparing those two. Now, let us see here. This is going to be very interesting. I already know it. The first thing we should note is this table 2, all-cause mortality. So, with more LDL-C reduction, you get a greater reduction in all-cause mortality. So, if LDL cholesterol was causing people to die earlier, like low LDL cholesterol was causing people to die earlier, then why, in this trial, does reducing LDL cholesterol, and this is an experimental study, by the way. So the earlier studies we were talking about, the opposite, where you got the cholesterol paradox, where you got the U-shaped curve, where you had at lower cholesterol levels, you had higher mortality than middle cholesterol, 130, 140 milligrams per deciliter, you had the lowest mortality, and then you get higher mortality as you go up again. In those studies, there's observational studies looking at what people's cholesterols were in the real world. In the real world, not whenever they're on a drug, not when they're assigned to anything. It's just like, let's see what your cholesterol levels are, let's see what your risk of dying is. In these studies, it's different. So they take people who have different LDL-C cholesterol levels. It doesn't matter. They take many different LDL cholesterol levels. They give people a drug that reduces their cholesterol levels at random. So either you get your LDL cholesterol level reduced, or you don't, you get a placebo, a sugar pill. And if you get your LDL-C levels reduced, you see a reduction in all-cause mortality, right? Why are you seeing a reduction in all-cause mortality whenever you have in the observational studies the highest all-cause mortality at the lowest cholesterol levels? It's because in these studies, what's causing the reduction in LDL cholesterol levels in these randomized controlled trials, what's causing the reduction is not any of these disease processes, it's the drug that's causing it. You're giving them a drug that's causing it, and you know that's the cause. So when you give a drug that causes the low LDL-C, you don't have these other confounding factors. You don't have the illness going along with it, which is going to end up killing the patient. You don't have that illness going along with it. No, the reason they have low LDL-C is because you gave them a drug, not because they have an illness to go along with it. All right, and then you can have sick people in both groups. You can have some sick people in the placebo-treated group, some sick people in the intervention group. But at baseline, most people are not going to be sick in these trials because at baseline, most people have higher LDL cholesterol levels. So whenever you take these people who have higher LDL cholesterol levels, you reduce their LDL cholesterol through a drug, and you know it's not through an illness, you see a reduction in all-cause mortality. That strengthens the case that the reason that you see a relationship between low LDL cholesterol levels and high mortality in the earlier study, in the earlier set of studies I was talking about, those studies that have been going on for 50 years, there's like 100 of them. The reason you're seeing that association is because of the illness Because once you reduce it experimentally, once you reduce LDL-C experimentally, you get an improvement, a reduction in all-cause mortality, as opposed to an increase. It's not the LDL-C itself, it's the illness that's going along with it. And when you reduce LDL-C itself, you get a benefit. This is how it works. You have randomized controlled trials on the one hand, which show a benefit, observational studies that are not as well controlled on the other hand, that show a harm. These studies that are very well controlled, where giving a drug to directly impact LDL-C, are the studies that you should be paying attention to if you're thinking about whether or not you should reduce your own LDL-C through a drug, right? Because these studies are caused by, these studies, that the observational studies, the reason that there's a problem, the reason that low LDL cholesterol associates with high mortality in these observational studies is because the illness is causing the low LDL cholesterol, and the high mortality is caused by the illness. It's not the low LDL cholesterol that's causing the death. The death is being caused by the illness, whereas in these studies, the low LDL cholesterol is caused by the drug. We know it's caused by the drug. So how you trust these studies when you're thinking about whether or not you want to take a drug. Because they're not confounded, they're much better controlled. Whereas these studies are epidemiologic observational studies, these studies are randomized controlled trials. You trust the randomized controlled trials because they give you the best evidence. And so you see very clearly in all the studies pulled together, you look at less intensive lowering versus more intensive lowering of LDL-C. If you have a baseline cholesterol below 100 milligrams per milliliter, you don't see any benefit for all-cause mortality, probably because your cholesterol is already low, so it's not going to help you to lower it more. For people with 100 to 130 milligrams per deciliter, you see a reduction in all-cause mortality about by 10%. From 130 to 160, again, about 10% reduction in all-cause mortality. And then above 160, about 30% reduction, because once you're getting to that level of LDL cholesterol, it becomes quite dangerous for your all-cause mortality. And once you then randomize to an LDL-C reducing therapy, you get a much bigger effect. But overall, you have about a 10% effect, 10% reduction in all-cause mortality in these trials, right? Experimental studies, gold standard studies, get rid of all those confounders, get rid of illness. Illness is not causing the low LDL-C. A drug is. You see what is the effect of the drug itself. It's always a good thing. It's always a good thing. These trials consistently publish a positive result. Sometimes they're not powered to detect a reduction in all-cause mortality because there's not enough people. They're powered to detect cardiovascular disease risks, but when you pool them all together, you see very clearly that they consistently point in the direction of lower all-cause mortality. Very, very consistently. And even in the individual studies that don't find themselves a statistically significant reduction in all-cause mortality, they all, almost overwhelmingly, almost all of them have a much lower all-cause mortality. And only some of them have like marginally above, like 2 or 3% increase, but this is because they're not powered well enough. It's not statistically significant, but like if you take 40 trials, like 38 of them will show a reduction in all-cause mortality. And then like 2 will show like 1 or 2% increase, and they don't have very many patients. So it was like a statistical fluke. So it's a very incredibly consistent finding. You get a really strong, robust reduction in all-cause mortality when you take these drugs. That's the short of it. That's the short of it. So if you want to reduce your risk of dying from cardiovascular disease, you want to take drugs like these. If your cholesterol is high and you have if you have substantial risk factors. And as I'll argue in some more videos, and I'm already arguing, everybody or almost everybody should take a statin, or everybody or almost everybody should take LDL cholesterol lowering medications. Some exceptions might be people who already have a really low LDL cholesterol, like in the 40s or 50s at baseline. It's not going to help them that much. It's not going to help them that much. Or people who have bad side effects from statins, which is a small minority of people, very, very small. But there are some people who have bad side effects, and so those people shouldn't take them either. And we'll talk about all that in a future video. But this is the way that the landscape ends up. So observational studies show this weird cholesterol paradox owing to illnesses and sickness among people who have low LDL cholesterol levels. This illness and sickness is caused by the low cholesterol levels are caused by the illness and sickness, and the high mortality rates are also caused by the illness and sickness, and the LDL cholesterol levels are not causing the high mortality rates. The low LDL cholesterol levels and the high mortality are each caused independently by something else, and LDL is not causing the higher mortality. And when you look at the randomized controlled trials, you see very consistently if you lower LDL cholesterol, you get positive effects on coronary heart disease and all-cause mortality, showing that there's not some other outcome that's made worse as the result of LDL-C lowering. There's not some other outcome like cancer that's made worse. It's not. It's not made worse. There's no higher risk of cancer with low LDL cholesterol that's lowered through a drug. Now, if you have low LDL cholesterol, you might have cancer, and that's causing the low LDL cholesterol. Okay? So be very careful about that. But that's not the LDL cholesterol causing the cancer. There's no increase in cancer in these studies. There's only a decrease in LDL cholesterol. And if you look at another paper, there's another paper that does a meta-analysis. It's interpretation of the efficacy and safety of statin therapy. I think it's in the Lancet. You can check that one out, and it shows very clearly across all different kinds of cancers, there's no change in the incidence of cancer. So there's no change in the incidence of cancer. In fact, there's even some indication that there's a slight anti-cancer effect of lipid-lowering medications. It's very small. It's not nearly as big as the effect on cardiovascular disease, but it's a very small benefit to cancer risk, all right, from lipid-lowering therapies. And then you have a really large benefit to cardiovascular disease. And so as a result, you get a huge reduction in all-cause mortality and risk of total death with these therapies. And this explains the so-called lipid paradox. Why is it that people with low LDL cholesterol have a higher risk of death, even though reducing LDL cholesterol causes a lower risk of death? It's because you're using two different study designs. One of them is confounded by having sick people in it, and the other is just causally reducing LDL cholesterol and seeing what the effect is. That's why. It's two different studies. One is a much weaker kind of evidence, and one is a much stronger kind of evidence. And so if you have really low LDL cholesterol naturally, you should think about that. You should be worried about it, especially if you see it drop quickly. But if you see your LDL cholesterol drop quickly, you're probably seeing other things that are also happening, like your weight is probably dropping quickly as well, so you'll know. But if you see a really drastic drop in LDL cholesterol out of nowhere and you haven't changed anything, you should worry about that. But that's not because LDL cholesterol itself is affecting anything negatively. It's because something that's negative is probably affecting the LDL cholesterol. You should worry about that. But LDL cholesterol itself, you want to get it as low as possible. We'll talk about that in another video. Like as low as possible, like 40 to 50 milligrams per deciliter. Okay, I hope this helped you guys. I hope this solved the problem. I hope this solved the question. I hope if anybody has any questions about this, that they can share this video with their friends and family. If anybody talks about, oh, well, lower LDL cholesterol levels have a higher mortality rate, therefore blah, 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 blah. No, please share this with your family. If somebody mentions that to you, please share this to your friends if one of your friends mentions it to you. Because they need to understand that the reason that this is the case is because of these aspects of the study, and this is not confirmed by randomized controlled trials, which are the gold standard for deciding whether or not we should treat something. We don't want to try to get higher LDL cholesterol. We want to reduce our LDL cholesterol to reduce our risk of death and of cardiovascular disease, which is an important thing. By the way, men, I want to tell you something. If you get cardiovascular disease, you know what subclinical cardiovascular disease causes before you even get a heart attack? Do you know what it causes? It causes this to happen. Your penis stops working. Your penis stops working. Your penis will stop working if you get subclinical cardiovascular disease, because guess what? Those same blood vessels in your heart, there's also those same kinds of blood vessels in your penis. And those blood vessels also get clogged. And there's ischemia there. Hi. And as a result of that, as a result of the ischemia there, your penis isn't going to function anymore. That was wonderful. The cleaning lady came in while I was talking about penis stopping working. It's just my day today. I don't think she's judging me too harshly. I hope not. But in any case, your penis will stop working if you get subclinical atherosclerosis. So one of the things you want to do is not get subclinical atherosclerosis. One of the things you want to do in order to not get subclinical atherosclerosis is to make sure your LDL cholesterol levels are low and your other risk factors are optimized, including blood pressure, smoking, diabetes, and those are the main ones. You want to make sure you don't have any of that stuff going on, and you want to also optimize your metabolic health. You don't want to just not have diabetes. You want to be relatively lean, and that will help you a lot to avoid atherosclerosis. But don't. It's not a joke. So if you have really high LDL cholesterol levels and you have all these other risk factors, optimized, it doesn't necessarily mean you're not going to get atherosclerosis. If you're say 45 years old and you have all these risk factors optimized, not even LDL cholesterol is high. Not even LDL cholesterol is high. You're going to have a 15% chance of having a cardiovascular disease event by the age of 75. And if you're 45 and you have one suboptimal factor, like LDL cholesterol is elevated, you have a 35% chance, or a 1 in 3 chance of having an event by the age of 80. So this is nothing to play around with. The benefits are very clear. The studies that show cholesterol paradox are confounded. The randomized controlled trials are very clear. And the observational evidence showing the information about risk factors is very clear. Everybody is at risk of cardiovascular disease. And optimizing your risk factors is a really smart thing to do. So if you have high LDL cholesterol, you should get it treated. And this is why these other studies aren't very good for us and don't help us to understand why, what to do with our LDL cholesterol. So if you enjoyed this video, again, please share it, click the like button, click the subscribe button, that would be much appreciated. Check me out on social media at TikTok, Instagram, Twitter, and at Patreon at Kevin Nbass, KVINNBASS, especially on Patreon. If you want to help me, support me, help me get more information out. I'm going to get a bunch of information out. We're going to get tons and tons of information out. Get information out to the people. It's what the people want. So you can help me by becoming a patron and donating on a monthly basis, and that will be an extraordinary help to me. Because the more somebody said like the other day, I was like, I can get babysitters for my kids. Yeah, man, like my baby mama, she has stuff that she needs to do. So sometimes I have to take care of the kids, so she does that stuff. So that's less time I can devote to making these videos. So we can hire a babysitter more and get more help to help us take care of our kids. So I take care of my kids a lot. I'm picking them up today, picked them up in the morning, was with them this weekend. So, but if you want to donate and help me by donating, it can help me to do more of these videos if you think these are helpful to people. And that's cool. So also check out my podcast at K-Bass Philadelphia on YouTube, and then also the Kevin Bass Show and the Kevin Bass Show on your local podcast directory, meaning Spotify or Apple Podcasts. And I said local podcast directory. That's funny. It's not your local podcast directory. Why do I always say your local podcast directory? There's no local podcast directory. It's international. There's no such thing as local podcast directories. Also, always get your podcast at local. Always get it local. It's the best. Support your local podcaster. Okay, cool. And then, of course, make comments. Leave a review on Apple Podcasts. That would be super helpful. Like, review. When are you guys going to leave more reviews? Leave more reviews for me. Get that. There's one review that stays there. It's a 3-star review, and it's like staying there at the top. And everybody sees that as their first review. At least I do on the app. It's like, we got to displace that man, whoever that man was. And that's just it's a bad review. It's a bad review. Although maybe I can address some of it in due time. Maybe this podcast is changing. Maybe I'm changing. And therefore, maybe people like that won't make those kinds of reviews anymore. But in the meantime, please make a review if you like what I'm doing, because I think it'll help. And then leave a rating. More ratings, the better. More people see more ratings. It's like social proof. Boom. Yeah. And don't forget, check me out for the next podcast after clicking the subscribe button. Click the subscribe button now. Like, okay, if you're on your phone, click over, swipe over, click the subscribe button, or click the follow button if you're listening to me on the podcast. And if you're on YouTube, click that subscribe button. That's awesome. Okay, I'm happy you just did that. Check me out for the next video/podcast. I'll see you guys around. Peace.